Hi, my name is Rob McLeod. I am the Secretary of the International Society of Electrocardiology, and it's my pleasure today to represent the Young Investigator Competition and describe to you how it works, and then share with you some of the video presentations that normally would make up a session we'd have at a normal or regular International Congress in Electrocardiology, which this year unfortunately is happening as a virtual event. So the Young Investigator Competition has been hosted and run by the ISE for many years now, and over the last few years we've had the pleasure of having our sponsor Eden, a biomedical device company, and we thank them again for their sponsorship. For anyone wanting to know more about this competition, how it operates, and especially motivate you to think about submitting in the future, please go to our website and read more about those details. I'll give you a brief overview, however, of how it typically works. It normally begins with uploading an abstract, just as with any other submission for the ISE, for the ICE, better said, in any given year. And once that abstract has been uploaded, it is evaluated by a set of judges, and then we choose finalists who make up a separate plenary session during a typical ICE conference. So the finalists get to present their research in a public setting, and then the judges evaluate them, ask them questions, and we get to the awarding of the prizes at the end of it all, and the winners are picked, and they also are highlighted on our website every year. This year, of course, is a little different, and so we have followed the formula in the sense that the applicants uploaded their abstracts, were evaluated, 3 reviewers each, and instead of having a live session dedicated to the 6 finalists, we've had to ask them to make videos, which the judges have viewed, followed by question and answer periods done interactively with them via an online meeting. And then we, again, settled on a set of 3 winners of the prizes. And at the end of this video, you'll get to learn who they are. So this year we started with 19 submissions from 5 different countries spanning the globe, from Canada to Hong Kong. We, again, narrowed that down to 6 finalists based on the quality and scientific value, the writing, all those aspects that make up a really powerful and compelling abstract. And then we had those 6 finalists create videos, which I'll share with you in a few minutes. At the end of that period, we had our Q&A again, as we usually do, and narrowed it down to 3 prize winners, who I'd be happy to share with you at the very end of this little video, in which we actually announce the final winners, first, second, and third prizes, and award them their recognition, at least, if not their money, for having achieved this really amazing honor. And a number of the winners of this competition have really gone on to substantial scientific careers. The president of our society at the moment is one of those winners. And it's a really amazing springboard into a successful career in our field. So I encourage you all to think about participating, or encourage your trainees to think about participating. Check out the rules, and once you've watched these videos, hopefully you get motivated to participate in future meetings. Now, the 6 finalists, I'll be showing each one of these 6 videos, and then we'll return at the end to see the final award winning. Thanks, and see you again soon.
Hi everyone, my name is Nancy Wang. I'm an internal medicine resident and Masters of Epidemiology candidate at Queen's University in Canada. Thank you all for the opportunity to present our research at ICE 2021 for the Young Investigators Award. I'm very excited to be here today. Today I will be talking about our project on the long-term outcomes in treated Lyme carditis, a case series. Thank you also to my co-authors for their help and advice along the way, and I've listed their names here. First, I should start and say that all of the authors of this abstract disclose that we do not have any conflicts of interest. So for some background, Lyme disease is a multi-system infection caused by Borrelia burgdorferi, a gram-negative spirochete transmitted by the Ixodes ticks. The host reservoirs include rodents, migratory birds, and other wildlife. Lyme disease is the most commonly reported vector-borne disease with an incidence of 8.1 cases per 100,000 people in the United States, over 65,000 cases per year in Europe, and in Canada, the incidence continues to rise with over 2,600 cases in 2019. In Ontario, Kingston and the surrounding area where our hospital is based is considered a Lyme endemic region. The clinical manifestations of Lyme disease is largely divided into three main phases. The early localized disease, which is characterized by this erythema migrans rash, with or without constitutional symptoms. The early disseminated disease, which involves acute cardiac involvement and neurological symptoms, as well as the late stage Lyme disease, which can occur months to years after the initial onset of infection and is largely dominated by symptoms of arthritis. Cardiac involvement is one of the hallmarks of early disseminated Lyme disease, with an incidence of 0.3% to up to 10% of cases. Of those with Lyme carditis, 9 out of 10 could present with high-degree atrial ventricular block, but they could have other presentations, including fulminant myocarditis. This illustration is from Jack, from a publication from our lab that summarizes the diagnosis and treatment of Lyme carditis. We can see here that cardiac involvement usually occurs within 1 to 2 months of initial tick exposure, and that due to the diverse and nonspecific nature of the presentation, patients often need to seek medical attention multiple times before arriving at the correct diagnosis. Since high-degree AV block usually resolves with antibiotic therapy, permanent pacemaker implantation is generally not required. As I mentioned, Kingston is a Lyme endemic region, and our lab has been very invested in advancing research on Lyme carditis. I'll just summarize some of the key highlights here. We initially published some case reports outlining the ECG progression of acute Lyme disease, the variety of nonspecific presentations that's associated with Lyme disease, some atypical rashes, and the use of temporary permanent pacemakers in the management of symptomatic heart failure or symptomatic AV block in Lyme carditis to promote patient mobilization. In 2018, our lab published a review of the Suspiciousness Index in Lyme carditis risk score, which very importantly tells us when the presenting AV block may be a consequence of Lyme. So in a review of 88 cases in the study, the authors determined a silk score with a co-star mnemonic. So that is constitutional symptoms, outdoor activity, sex equals male, tick bite, age less than 50 years, and a rash of erythema migrans. Each scored from 1 to 4 points. The total sum score then stratifies the patients into a low, intermediate, or high suspicion for Lyme carditis of those presenting with atrial ventricular block. Cynthia from our lab then subsequently led 2 publications on the systematic approach in diagnosis and treatment of Lyme carditis, and subsequently a JACC Topic of the Week review. This was the first and only algorithm to help diagnose and manage high-degree AV block. So I'll just run through it very briefly. When a patient presents with high-degree AV block, the silk score should be used to evaluate the risk of Lyme carditis. If the patient has a score of 3 or more, they fall into the intermediate or high risk for Lyme disease, and a serological test for Lyme should be ordered. Empiric antibiotics via intravenous should also be used, and cardiac monitoring plus or minus a temporary permanent pacemaker for hemodynamic support should be considered. The IV antibiotics should then be continued for 10 to 14 days, followed by a choice of oral antibiotics. In our center, this is usually doxycycline. And in most cases, there's subsequent resolution of AV block, at which time a stress test should be considered or should be performed to evaluate AV nodal conduction prior to discharge. The most important thing to note from this algorithm is that it finishes at 4 to 6 weeks. So we have to wonder what happens to the patients with Lyme carditis who've been properly treated for Lyme in terms of long-term outcomes. Are there lasting symptoms? Is there a complete resolution of conduction abnormalities? Or do patients go on to eventually require permanent pacing? So the objective of this study was to determine the long-term outcomes of patients with serologically confirmed Lyme carditis after appropriate antibiotic treatment. So for our methods, this is a prospective case series where we have 7 patients with serologically confirmed Lyme carditis treated by the standard protocol that we developed. This includes appropriate antibiotic therapy and a pre-discharge stress test follow-up at 4 to 6 weeks. The patients who had follow-up of greater than or equal to 12 months were included in this study. And again, these patients had a history and physical as well as a 12-lead ECG. All of our initial patients presented with second or third degree AV block, and the symptoms included presyncope, syncope, palpitations, shortness of breath, malaise, and erythema migrans. Of the 7 patients, 6 were male. The median silk score was 7.0, and as you recall, a score of 7 to 12 is considered high risk. During the hospitalizations, 2 required temporary permanent pacemakers, and 2 had an abnormal echocardiogram during the admission, with 1 was showing some evidence of diastolic dysfunction. The median time to resolution of conduction abnormalities was 3 days. On the mean follow-up of 20.8 months, all patients were asymptomatic and had resumed normal physical activity. The median heart rate was 49, the PR interval was 150, and the median QRS interval was 92 milliseconds. Here, I show the progression of AV block in each of these 7 patients. This is probably the most important slide of the presentation. On the left, I show the admission ECG. In the middle, I show the ECG at time of discharge, and on the right-hand side, I show the long-term ECG, again with a mean follow-up of 20.8 months. All the patients initially presented with narrow QRS indicating predominantly AV nodal disease, with patients 1, 3, and 5 in complete heart block, patients 2 and 6 with 2 to 1 block, and patients 4 and 7 with Mobitz 2 block. On discharge, all patients underwent a stress test showing 1-to-1 AV conduction with a heart rate of greater than 120 beats per minute. 3 patients, that's 1, 5, and 7, had residual first-degree AV block, though the PR interval was less than 300 milliseconds. At follow-up, all the conduction abnormalities had resolved, and all patients were in sinus rhythm. Here we present the first case series of long-term follow-up of patients with treated Lyme carditis. And at a mean follow-up of 20.8 months, all were asymptomatic and had resumed normal activity with no evidence of conduction abnormalities. Most importantly, none required permanent pacing. This is a very important issue as the presenting age for Lyme carditis is very young, and subjecting a patient to permanent pacing might involve multiple replacement procedures throughout their lifetime, which carries with it an infection rate each time. There's currently no clinical precedence for ongoing monitoring of patients with Lyme carditis, but we believe this is very important. For the next steps, we hope to establish a multinational prospective database for the long-term follow-up of Lyme carditis. Here I've included my references. I'm very much looking forward to your questions on Friday, and thank you again for the opportunity to present our research.
Greetings, judges and audiences. My name is Sharon Lee, and it is my pleasure today to present my territory-wide study comparing the ventricular tachyarrhythmia risk in pediatric or young and adult Brugada syndrome. Brugada syndrome is the most prevalent ion channelopathy found in Asia. It typically manifests in the 4th to 5th decades of life, but those presenting in the childhood is reported to be of poor prognosis with a higher risk of sudden cardiac death among symptomatic patients. Due to the small population of pediatric Brugada patients, it can be challenging to identify the specific differences between the pediatric and adult populations. As a result, the application of adult-based risk stratification criteria upon the pediatric population may result in misinterpretation of sudden cardiac death risk. The present study, therefore, aims to demonstrate the difference in clinical and electrocardiographic presentation between pediatric or young and adult Brugada patients. The study cohort included consecutive patients diagnosed with Brugada syndrome between January 1, 1997 to June 12, 2020 by public hospitals in Hong Kong. Centralized electronic health records from the hospital authority were reviewed for the identification of patients and extraction of baseline clinical and electrocardiographic data. The diagnosis of Brugada syndrome was made initially by the case physicians, then confirmed by two cardiologists through the review of case notes, documented electrocardiograms, treadmill test results, and genetic reports. The diagnosis of Brugada syndrome was made based on the 2017 criteria proposed by the expert consensus statement. The cohort was divided into subgroups based on the patient's age at initial presentation. Patients presenting at or below the age of 25 were categorized into the pediatric or young subgroup, with the remainder of patients categorized into the adult subgroup. We have adopted this age cutoff from Gonzalez et al.'s study on the risk stratification of young Brugada syndrome patients. Subgroup differences of categorical variables were compared through Fisher's exact test, whilst discrete and continuous variables were compared by the Mann-Whitney test. The primary outcome of the present study is the first post-diagnosis sustained ventricular tachycardia or fibrillation. Cost regression analysis was used to identify the independent predictors. Univariate predictors with a p-value of less than 0.1 were selected for multivariate analysis. Separate models with and without the inclusion of predictors from the baseline electrocardiogram were established. In total, the study cohort consists of 545 consecutive patients with a mean age of initial presentation at 50 years old and a mean follow-up period of 83 months. The adult subgroup consists of 505 patients with a mean age of initial presentation at 53 years old and a mean follow-up period of 84 months, whilst the pediatric/young subgroup consists of 45 patients with a mean age of presentation at 20 years old with a mean follow-up period of 74 months. A total of 7 pediatric or young patients and 59 adult patients suffer from incidental ventricular tachyarrhythmia on follow-up. This is equivalent to an incidence rate of 17 and 25 cases per 1,000 patient years for the respective patient subgroups. In terms of significant intergroup differences in baseline clinical presentation, there was a significantly greater proportion of pediatric or young patients presenting with fever at the onset of Brugada pattern or with a family history of Brugada syndrome. At the initial presentation of Brugada pattern, a significantly greater proportion of adult patients were diagnosed asymptomatically, whilst pediatric or young patients were more commonly diagnosed after the manifestation of syncope. On the other hand, there was a greater proportion of adults with concomitant arrhythmias than pediatric or young patients. In terms of baseline electrocardiographic indices, pediatric or young patients had a significantly higher heart rate, which resulted in a shorter QT interval. The differences were resolved after correcting for the heart rate. The pediatric or young subgroup also had a more rightward deviated QRS axis than the adult subgroup, likely reflecting the more vertical positioning of the heart in the thorax in young people. Different predictors for time to first post-diagnosis ventricular tachyarrhythmia were found between subgroups. Under multivariate analysis, the initial presentation of type 1 Brugada pattern is predictive when baseline electrocardiographic predictors were excluded. When baseline electrocardiographic predictors were included, both an initial asymptomatic presentation and a higher degree in P-wave axes were found to be protective against spontaneous ventricular tachyarrhythmia. Given that the normal P-wave axis is within 0 to 75 degrees, a higher P-wave axis suggests a more right-deviated net direction of atrial depolarization. An abnormal P-wave axis is suggestive of adverse atrial remodeling and a predictor of atrial fibrillation, which may reflect greater arrhythmia potential. On the other hand, the pediatric or young status was found to be predictive of a shorter survival against post-diagnosis ventricular tachyarrhythmia. However, within this subgroup, only the initial presentation of ventricular tachyarrhythmia at diagnosis is found to be predictive when baseline electrocardiographic predictors were excluded. The Kappa-Meier survival curve compares between the adult subgroup, represented by the orange line, and the pediatric/young subgroup, represented by the blue line, in their probability of being free from ventricular tachyarrhythmia during follow-up. It illustrates the significant intergroup difference in the ventricular tachyarrhythmia-free survival, with p-value of 0.012 calculated by the log-rank test. The drop in patient number is solely due to the occurrence of ventricular tachyarrhythmia during follow-up, with no patients lost to follow-up. This is the first territory-wide cohort study, to the best of our knowledge, comparing pediatric or young and adult patients of Brugada syndrome in Asia. There are several major findings of the present study. First of all, there are significant differences in clinical and electrocardiographic presentation amongst adult and pediatric Brugada patients. Secondly, pediatric or young Brugada patients have a higher risk for spontaneous ventricular tachyarrhythmia. And thirdly, different predictors towards spontaneous ventricular tachyarrhythmia were found between adult and pediatric/young Brugada patients. The major strengths of the present study include being the first study that compared the characteristics of pediatric or young and adult Brugada patients. Moreover, finding predictors of post-diagnosis ventricular tachyarrhythmia for both adults and pediatric or young patients. And thirdly, demonstrating the holistic differences in clinical and electrocardiographic aspects of adult and pediatric or young patients. And finally, having a substantially long follow-up time. However, several limitations should be noted. First of all, the retrospective nature of the study is inherently subjected to selection and information bias. However, consultations were performed at least annually for most patients. Hence, the patients were closely followed up. Also, it should be noted that the documented syncope may not be of cardiogenic origin, hence it may be unrelated to Brugada syndrome. Furthermore, changes in guidelines for investigations and diagnostic tests throughout follow-up introduced inevitable inconsistency in indications for different tests. Due to the limited availability of public genetic service, not all patients underwent genetic screening, and hence genotype-phenotype correlations cannot be established with greater degrees of certainty. In conclusion, clinical and electrocardiographic presentation of Brugada syndrome vary between the pediatric or young and adult population. An individualized approach should be adopted for the management of younger patients. Finally, a combination of clinical and electrocardiographic parameters can be applied in the risk stratification of Brugada patients.
Hello, my name is Anastasia Beery. I'm the lead author of this project, and today I'll be talking about how decreased depolarization vector magnitude may help identify events in patients with long QT syndrome. So long QT syndrome is a group of potentially lethal, disordered myocardial repolarization conditions characterized by specific clinical and familial history manifestations. These patients are at an elevated risk for channelopathy-induced delayed myocardial repolarization and life-threatening cardiac events. Long QT syndrome may be acquired or caused by inherited or sporadic de novo genetic mutations. Recent studies have shown computed aspects of vector cardiography, or VCG, can be used as diagnostic or predictive tools in long QT syndrome type 2, hypertrophic cardiomyopathy, Kawasaki disease, tetralogy of flow, and some other conditions. Some of these measurements include T-wave morphological analysis and also spatial QRST angle measurements, where the QRST angle is the spatial differential in orientation between the depolarization and repolarization of myocardium. Unfortunately, these may be impractical for widespread clinical use because they do require complex software and calculations, and that may not be readily accessible for all physicians or clinicians. Also, these markers do possess less generalizable predictive value, So another more available measurement is the T-wave vector magnitude. This is more easily derived from standard 12-lead ECGs. You could do that by measuring the T-wave loop's maximal distance from the origin or through calculation using T-wave amplitudes in 3 quasi-orthogonal leads, specifically lead 2, V2, and V6. Studies have shown there is significant prognostic value in anticipating future ventricular tachycardia in female genotype positive long QT syndrome type 2 patients. So with all of this variable symptomology across long QT patients, there would be great utility in the ability to predict the risk of future cardiac events for each of these patients from some accessible baseline measurement. So we attempt to further the previous study and answer whether T-wave vector magnitude from baseline ECGs is an effective predictor of future cardiac events for all genotype positive long QT syndrome patients. We did a retrospective review. We looked at patients at the University of Minnesota between 2010 and 2012, and at first included carriers of any known long QT syndrome disease-causing mutation. We had an additional ECG requirement that necessitated patients have flat baselines in leads 1, 2, and V1 through V6, so less than 0.1 millivolt of movement. And this was to ensure that we had adequate assessment of voltage parameters. So that means poor quality ECGs or those with movement artifacts were excluded. We obtained clinical data from hospital digital notes and results sections with information on demographic characteristics, personal and family medical history, ECG findings, therapy, including QT prolonging medications, and events during long-term follow-up. We also collected beta blocker usage information, and this was in order to perform time-dependent assessment of possible impact on the incidence of cardiac events. The primary endpoint of this study was to occurrence of a first cardiac event that included cardiogenic syncope, aborted cardiac arrest requiring defibrillation as part of resuscitation, long QT syndrome-related sudden cardiac death defined as abrupt in onset, and if witnessed, not explained by another cause. If not witnessed, not explained by another cause, or by implantable cardioverter defibrillator therapy, including anti-tachycardia pacing or shock therapy. The ECG measurements were conducted while blinded to patient clinical characteristics. The corrected QT was obtained using Bizet's formula, and spatial QRST angle was calculated by the Peaks method, utilizing a Cohort method from the 1990 paper. The QRS vector magnitude was defined by the transformed Cohort quasi-orthogonal method, using the beat with stable baseline median when it met the standard, and it was calculated as the square root of the sum of the squared QRS waves in leads V6, 2, and 1/2 of the QRS wave amplitude in V2. T-wave vector magnitude was defined and calculated similarly, but of course using T-wave vector magnitude instead of QRS vector magnitude. We also calculated the magnitude of the spatial ventricular gradient, SVG, and the SVG elevation and azimuth angles. We statistically analyzed our data using SPSS. Shapiro-Wilk testing was done for normality. Student t-test, chi-square, and analysis of variance identified significant differences between the groups. Receiver operating characteristic curve analysis identified threshold values for BCG parameters associated with cardiac events. Kaplan-Meier method assessed cumulative probability with significance testing by log rank statistic. Cox proportional hazard model found the independent contribution of clinical and genetic factors to the first occurrence of time-dependent cardiac events from the time of the initial ECG through the end of follow-up. Proportionality assumption was tested using time-dependent covariates created from interactions between survival time and various covariates, and Pearson and Spearman correlation coefficients were used as appropriate for parametric and non-parametric data. So here we have our table 1 showing our demographics. It compares 26 patients without cardiac events and 15 patients with cardiac events. At baseline towards the top, we can see statistically significant values differentiating the groups, including age of patients and QRS vector magnitude and azimuth of the SVG. Towards the bottom half, we see statistically significant final ECG parameters between the two groups, still including QRS vector magnitude and azimuth of SVG, this time also including the T-wave vector magnitude and QRS duration. Our table 2 shows our hazard ratios for parameters tested. We see that beta blocker use was found to be protective, along with a lower baseline QRS vector magnitude, and specifically a QRS vector magnitude of 1.43 millivolts or lower. When age, QRS vector magnitude, beta blocker use, and genotype were taken into account, only the QRS vector magnitude showed significance. Our figure 1 shows our Kaplan-Meier curve. This was for survival to ventricular tachycardia or sudden death, whether aborted or occurred, and using the QRS vector magnitude cutoff of 1.43 millivolts or lower, this figure demonstrates the significant Kaplan-Meier curve for separation of those cardiac events and those without cardiac events. To recap our results, this study contains several items of significance which provide evidence that measuring T-wave vector magnitude along with other BCG measurements from baseline ECGs can be effective in predicting cardiac events in long QT syndrome patients. As we saw in Table 1, some baseline and final parameters showed significant differences between patient groups who did not experience cardiac events and those who did. Baseline BCG values that showed significance included the QRS vector magnitude, azimuth of SVG, and final BCG parameters which showed significance included the QRS vector magnitude, T-wave vector magnitude, and again the SVG azimuth. QRS vector magnitude measurement also holds significance in relation to the Kaplan-Meier curve, which was our figure 1, and this can likely be attributed to subclinical events precipitating cardiac changes, which are captured on the ECGs taken near the time of the cardiac events. So as we noted before, long QT syndrome patients do have an elevated risk for cardiac events, and as such, there would be great utility in the ability to easily and consistently trend predictive measurements from standard 12 lead, such as by using T-wave vector magnitude. This would be much more accessible to providers and allow us to clinically monitor changes from baseline values over time. This would provide earlier detection and predictive identification of cardiac events, which in turn would ultimately provide appropriate intervention, improve timely preventative care and management of symptomology, and improve outcomes and survival from cardiac events. In conclusion, this study does show that there is evidence that ECG and derived BCG parameters, including the T-wave vector magnitude, can be effective tools in early identification and prediction of cardiac events in patients with long QT syndrome. Thank you for your time.
Hi, my name is Wiktoria Tomków. I am third-year medical student at Wrocław Medical University, and I would like to present you results of our study, which is factors influencing the interatrial conduction disorders in geriatric patients. The main goal of the study was to find the correlation between Bachmann's bundle block and coexisting age-related diseases. The progression of functional and structural changes within atria result from numerous pathologies, such as hypertension, ischemic heart disease, heart failure, chronic kidney disease, or diabetes. These comorbidities cause necrosis or apoptosis of the cardiomyocytes and consequently cardiac remodeling. The result of these processes is formation of many potential arrhythmic foci or conduction disturbances, including interatrial conduction disorders, which is the topic of our study. Our study included 210 patients aged 65 to 94. 170 of them were women. We compared several parameters including age, fasting glucose levels, prevalence of chronic kidney disease, ischemic heart disease, and heart failure in different stages of Bachmann's bundle block classified by ECG analysis. The main conduction pathway between right and left atrium is the Bachmann's bundle. In partial Bachmann's bundle block, as a result of delay of the polarization of the left atrium relative to the right atrium, the P-wave duration is over 120 milliseconds and shows a characteristic notch in its morphology, visible in leads 2, 3, and AVF. Partial Bachmann's bundle block is often accompanied by left atrium enlargement. Actually, it has been considered that so-called P. mitrale is better explained by the underlying interarterial conduction disorder seen in partial Bachmann's bundle block, rather than by the influence of increased distance for impulse transmission in left atrium enlargement. In case of complete Bachmann's bundle block, as the conduction goes through the muscles of coronary sinus, in leads 2, 3, and AVF, the biphasic positive-negative morphology of the P wave is observed. Sometimes in lead AVF, the P wave might appear completely negative. And here are the results. As you can see, the stage of Bachmann's bundle block was correlated with age, glucose levels, and chronic kidney disease. And there's borderline statistical significance in patients with ischemic heart disease and heart failure. So let's dig into that. Patients who presented with interatrial conduction disturbances were on average older. Mean age significantly differed in group with normal conduction, 76, and the group with incomplete and complete Bachmann's bundle block, 80 and 78 respectively. Also, fasting glucose levels was higher in group with interatrial conduction disorder, 104 mg per deciliter in normal group, and 119 and 117 in incomplete and complete Bachmann's bundle block. Common risk factors in patients with diabetes may contribute to atherosclerotic plaque formation and endothelial injury, leading to ischemia-mediated interatrial conduction delay, as well as enhancement of the risk for thrombosis. The underlying cause for this significant correlation between diabetes and interatrial block is chronic hyperglycemia. There was no direct correlation to creatinine levels. However, chronic renal disease independent from creatinine levels showed an increased number of patients with interatrial conduction delay. There was 5.2 patients with chronic kidney disease in normal group versus 18.8 and 14.5 in incomplete and complete Bachmann's bundle block respectively. It might be a result of electrolyte disorders which are observed in chronic kidney disease, including hypocalcemia. This leads to disturbances in transmission and conduction of electrical impulses in cardiomyocytes. Disorders within the uremic heart may also lead to delayed atrial and ventricular depolarization and eventually prolongation of the P wave. There was no direct correlation between interatrial conduction delays and heart failure as well as ischemic heart disease. However, patients presented borderline statistical significance. The incidence of ischemic heart disease positively correlated with the severity of interatrial conduction disturbances. In normal group, 14.3% of patients suffered from ischemic heart disease in comparison to incomplete with 25% and complete with 30.4% of patients with ischemic heart disease. The most important limitations of the study were the quality of the ECG recordings. While analyzing, we often had to take photos of the ECG strips so we could zoom in and exactly determine where the P wave started and ended. We solved this problem for the upcoming prospective study by using the ECG machine that allows us to adjust the amplitude and paper speed up to 1000 mm per second. Small sample size also had significant impact on statistical analysis, especially in case of borderline statistical significance presented in ischemic heart disease and heart failure patients, which will be further investigated on bigger population. The presence of incomplete and complete Bachmann's bundle block is related to advanced age and increased fasting glucose levels. Chronic kidney disease constitutes another factor related to interatrial conduction disorders. However, assessment of interatrial conduction disorders is still an underrated indicator of risk of developing atrial fibrillation. Medical standard screening procedures should be adapted to put an emphasis on patients with chronic kidney disease and diabetes and test these patients systematically for interatrial conduction disturbances with potential to result in atrial fibrillation. Early detection of interatrial conduction disorders will allow to improve the quality of healthcare and reduce the risk of serious complications resulting from atrial fibrillation. And that's it. Thank you for your time. Goodbye.
I'm Gabriela Paixão. I'm a cardiologist and electrophysiologist from Brazil. I'm going to present Deep Neural Network Estimated Electrocardiographic Age as a Mortality Predictor, data from Cohort study. I have no disclosure for this presentation. We have the telehealth network of Minas Gerais that's responsible for the ECG reported in Brazil. The Minas Gerais is a state from the southeast of Brazil. We have a lot of small counties and with low human developed index that perform the ECG in the basic unit and send by internet for the cardiologist report. We have performed more than 5 million ECGs, especially in our state, in Minas Gerais, but also in another states from Brazil in the north and the northeast. As you all know, the ECG is a low-cost, a simple and easy access exam. It's the screening tool for cardiomyopathies, and it's also used for the follow-up of patients with cardiac diseases. The cardiologist report is still the gold standard for the ECG report, especially for the ECG abnormalities. We have also the automatic report, as example, the Glasgow University software and the Minnesota code. And nowadays, a lot have been studied about the machine learning, the artificial intelligence in the ECG. The artificial intelligence can diagnose some arrhythmias, especially in the emergency department, and also has been published that the artificial intelligence can predict the age from the patient only for the ECG report. And here we want to study if the ECG tracing can give more information for the artificial intelligence as the ECG age, and if this ECG age could be a tool for the assessment of the risk of death in the general population, seeing that the ECG age could be the biological, the vascular age. So we have our database, that's the Cohort study, it's clinical outcomes in digital electrocardiography, is an ECG database with clinical data and medication that was linked to the hospitalization and mortality data from our country. We have more than 2 million ECGs. So we use it for the machine learning, the code database that was divided in 3 sets. 80% was used for training the machine learning, for training the machine. 5% for validation and 15% for testing. So about the 2 million ECGs that we have, that gave us about 1,500,000 patients, all older than 16 years old. The machine learning that we used was the convolution neural network architecture. That's the residual neural network that was performed like this figure here. And the model was validated in 2 external cohorts. So we train it and validation in the code, and then we tested in the code 15%, and in the ELSA Brazil, that is a cohort from Brazilian public servants, and also in the Samitrop, that is a cohort from Chagueires patients. The statistical analysis was performed. We used the R-square metric to see the mean average error between the ECG age predicted by artificial intelligence and the chronological age, and the patients were divided in 3 groups. First, it was the patients with the ECG age, 80 years or more, less than the chronological age. The second was the patients with ECG age within a range between 8 years from their chronological age. And third, it was the patient with 8 years or more greater than the chronological age. We use it for the mortality analysis, the Cox regression. It was adjusted by age and sex, and then age and sex and clinical conditions. And we also performed mortality analysis only with normal ECGs. The base data from the patients in the 3 cohorts, it was a little bit different. In the code 15%, we had the mean age about 50 years, the same as ELSA. In the Samtrop, the patients was older, about 60 years. About 1/3 of the patients had hypertension in all 3 cohorts, and mainly were women. The follow-up in the code, it was 3.4 years, the mean follow-up. In ELSA, 9.8 years, in Samtrop, 2.1 year. And the number of events is deaths. The code was 3.7%, in ELSA 4.3%, in Samtrop 6.4%. Here we can see the difference between ECG age and the chronological age. As you can see in this diagram, both in ELSA and Samtrop, there was a disagreement between the ECG age and the chronological age, with an R-square about 0.3. In the code cohort, we had an R-square about 0.7. As we go to the mortality analysis and divide it by the 3 cohorts, we can see first, adjusted by age and sex, that an ECG age younger than 8 years than the chronological age was a protect factor in the code in the ELSA, but not in the Samtrop. In the ECG age older than 80 years was a risk factor. And the findings were consistent after adjusting for hypertension, diabetes, and smoking, after adjusting, including dyslipidemia, and after including obesity. Here are the Kaplan-Meier curves that we can see. Here in red is the patients with the ECG age older than 8 years. Here in green with the ECG age younger, in blue in the range about 8 years. As you all can see in the 3 cohorts, the ECG age with more than 8 years older than the chronological age was a risk factor for overall mortality. Going to the normal ECG, and that we have data only from the code and the ELSA, because in the Samtrop, the patients had Chagas disease. Therefore, their ECGs were all had some kind of abnormality, minor or major. We can see that in the patients from the code, the findings of protected and risk remained. Here in the younger ECG age, it was also a protected risk, and in the older ECG age was a risk factor, and the findings remained after adjusting for cardiac risk factors. We couldn't see the same results in the ELSA Brazil because it was smaller cohort. Here we have about 80,000 patients, here about 7,000 patients. And the number of events here in the ELSA, it was lower than in the code. That's why we believe that we couldn't find the same results. So to conclude, we showed that the predicted ECG age may reflect a biological age and vascular age that is different from the chronological age, could be a promising tool for a risk prediction or a risk stratification of the general population. The chronological age is data that is really easy to obtain. Almost all exams performed, we have this data available. And we can use this model for training other cohorts, other databases to see if the findings remain the same. And moreover, we could predict mortality even in normal ECGs. So that suggests for us that the machine learning can see some markers or abnormalities that are hidden from the human eyes that we can see. So they might be useful for gaining more information from the ECG tracing that we use traditional as ECG abnormalities or abnormality ECG measures. So this is the co-team, it's the most professional team, and I want to thank you all for the attention. I'm available after for any questions.
My name is Guilherme D'Agostin, and on behalf of all our work group, we are delighted to present our work in such a prestigious contest at the Young Investigator Award. And we are going to present our work entitled Relationship between Ventricular Repolarization Parameters and the Inducibility of Ventricular Arrhythmias during Electrophysiological Study in Patients with Coronary Artery Disease. The authors declare that there are no conflicts of interest in this presentation. Sudden cardiac death occurred in 80% of the cases in patients with pre-existing coronary artery disease. Nevertheless, less than 20% of the events occur in high-risk subgroups, and more than 50% of them occur as a first recognized clinical event in the general population. Left ventricular ejection fraction is the most commonly used predictive risk factor of sudden cardiac death in clinical practice, even though it has a limited sensibility since most of the cases occur in patients without significant dysfunction. Parameters of ventricular repolarization demonstrated to be useful tools for risk stratification in various clinical conditions, since they were associated with the risk of malignant ventricular arrhythmias and mortality. Given these facts, we conducted a study with the primary objective to evaluate the association between ventricular repolarization parameters measured on the 12-lead ECG and ventricular arrhythmia inducibility during electrophysiological study in patients with coronary artery disease. As secondary objectives, we aim to evaluate the association of these parameters and ventricular arrhythmia inducibility based on the previous history of acute coronary syndrome and left ventricular ejection fraction, and also determine the relationship of demographic, clinical, and complementary exam variables associated with arrhythmia inducibility in the studied sample. This was an observational, cross-sectional, single-center study that included patients of any age or gender with coronary artery disease, defined as previous ACS or compatible symptoms associated with an anatomical or non-invasive test with a result compatible with myocardial ischemia that were submitted to electrophysiological testing between January 2013 and December 2017. We excluded patients with any other cardiomyopathies with a previous or a current episode of myocarditis with channelopathies, and also those without an interpretable 12-lead ECG in the 6 months preceding the EPS. Electrocardiographic parameters were measured using the CardioCaliper software. The QT interval was measured on the second beat in lead 2 by the tangent method. The corrected QT was calculated by Bassett's formula. Its dispersion was calculated by the difference between highest and lowest values measured in the 12-lead ECG. The T-peak end interval was measured on the first beat in lead V5 by the tangent method. Its dispersion was calculated by the difference between highest and lowest values measured in the 12-lead ECG, and the peak and QT ratio was calculated between the values measured in the first beating lead V6. The Eps protocol included programmed ventricular stimulation with 2 basic cycles and up to 3 extra stimuli at the apex and the right ventricular outflow tract, and also rapid stimulation at the same sites with an interval of coupling up to 250 milliseconds or 2-for-1 ventricular capture. We define as malignant arrhythmias sustained ventricular tachycardia, ventricular flutter, and ventricular fibrillation according to the definitions based on the guidelines for the diagnosis and management of ventricular arrhythmias published in the Circulation in 2018. Given the absence of robust evidence in the literature on the incidence of malignant arrhythmias induced in the EPS in the setting of coronary disease, we assumed a rate of 50%, which makes up the largest variance and therefore raises the largest sample. Considering a 95% confidence level, a sample of 151 patients will be necessary to achieve such significance. 182 selected patients met inclusion criteria. 5 of them were excluded, and in the final analysis, we included 177 patients. Univariable analysis of categorical variables were made by Fisher's exact test and chi-square test. Quantitative variables were assessed by student's t-test for independent samples and Mann-Whitney's non-parametric test. The condition of normality was assessed by the Kolmogorov-Smirnov's test. Multivariable analysis was made by logistic regression model, including as explanatory variables those that showed significance in the univariable analysis. Wald's test was used to make decisions about the significance of variables. The measure of association used was odds ratio with a 95% confidence interval. For model validation, we used Hosmer-Lemschell's test and the area under the ROC curve. Values of B below 0.05 indicated statistical significance. Demographic and clinical characteristics showed a mean age of 65 years. 83.6% of the sample was of male gender, with a mean LV ejection fraction of 37.5, and above 50% of the patients had an LV ejection fraction below 35%. Regarding previous coronary events, 3/4 of the sample had a previous ACS, and half of them had a previous STEMI. Regarding symptoms, most of the patients were asymptomatic or had mild symptoms in the last clinical report evaluation. Less than 2.5% had symptoms at rest. 16.9% of the patients had a previous abort sudden cardiac death. Regarding comorbidities, 90% of the patients had hypertension, 2/3 dyslipidemia, 41% diabetes, and above 31% a previous episode of syncope. Regarding medications in use, the treatment was in accordance with the guidelines for the management of heart failure with reduced ejection fraction and ischemic heart disease. Noteworthy, 41% of the patients were in use of amiodarone. Univariable analysis showed that male gender reduced ejection fraction, especially when below 35%, and the previous use of amiodarone were related to arrhythmia inducibility in the electrophysiological study. The QT interval was significantly longer in those patients with arrhythmia inducibility during electrophysiological testing. The other parameters of repolarization did not show such a relationship. Multivariable analysis showed that male gender, LV ejection fraction below 35%, and the QT interval were associated with in the induction of arrhythmias in the tests. And with each 10 millisecond enlargement in the QT, there was a 7% increase in the chance of inducible arrhythmia. The ROC curve showed a cutoff point of 452 milliseconds with a 61% accuracy for arrhythmia induction prediction. Using the cutoff point indicated by the ROC curve, multivariable analysis showed that male gender, amiodarone use, reduced LV ejection fraction, and the QT above 452 were associated with the proposed outcome. Univariable analysis showed that the previous event of acute coronary syndrome did not show a relationship with arrhythmia inducibility in the electrophysiological study. In the patients with the previous acute coronary syndrome, the QT interval was significantly longer in those patients with arrhythmia inducibility. None of the other parameters showed that finding. In those patients without previous acute coronary syndrome, none of the ECG parameters were related to arrhythmia inducibility. The RAC curve determined a 432 millisecond cutoff point to predict with an accuracy of 62.8% the induction of arrhythmias in those patients with a previous acute coronary syndrome. Univariable analysis showed that in those patients with LV ejection fraction below 35%, none of the repolarization parameters were related to arrhythmia inducibility. In those patients, when we combined LV ejection fraction below 35% and a QT above 452, they had a larger chance of arrhythmia inducibility that was confirmed in multivariable analysis with an odds ratio of 5.44. Univariable analysis in those patients with left ventricular ejection fraction above 35% showed that the QT dispersion was significantly larger in those patients with arrhythmia inducibility, and a cutoff point of 20 milliseconds had an accuracy of 63.8% for the proposed outcome with a negative predictive value of 81.3%. So we conclude in the primary objective that the increase in the QT interval was associated with malignant ventricular arrhythmia inducibility during EPS in the patients with coronary disease, and with 10 milliseconds of enlargement in the parameter, there was a 7% increase in the chance of inducible arrhythmias. A QT above 452 showed moderate predictive capacity for the outcome. As secondary objectives, we conclude that the QT interval was related to the induction of arrhythmias during the procedure in the patients with previous ACS. A QT above 432 showed moderate predictive capacity in the subgroup of patients. The combination of LV ejection fraction below 35% and a QT above 452 predisposed to a 5.4-fold increase in arrhythmia inducibility. A QT dispersion below 20 milliseconds had a high negative predictive value in the subgroup of patients with LV ejection fraction above 35%. And the male gender, the use of amiodarone, and LV ejection fraction were also associated with the induction of MVA in the studied sample. Thank you.
So it's a pleasure to be here in this online ceremony in which we will give the awards for the young investigators that applied for the ISE 2021 Young Investigator Award. I would like to say only a few words about this prize. First, I'm a previous awarded person, so a previous awardee. Some 20 and some years ago, I applied for this prize, and it was very important for my path, my career to receive it, an international prize, and also very important to direct my research for ECG. And by this time, I worked mostly with Holter monitoring in autonomics, but it was something very important. The second aspect is that we are relatively old, and we publish a lot, and we have a lot of, but we understand that the richness and the strength is in the youth. We understand that the will of doing research, of finding new things, of giving contributions to science is the most important of a scientific association like ours. So we are very pleased to conduct this competition, this award every year, and we are very happy to be here with you. We would be very, very happy to be in person. There are some things that's not, the Zoom can facilitate a lot of things, but to be in person is it's really, really worth, it's worth a lot. So we are very pleased to be here, and we would go to the most important part of this session. And I will ask first Rob McLeod, who is the secretary of the International Society of Electrocardiology, to give the third prize, please.
Yes, Thank you, Tom, and thank you all for participating in the competition this year. I have been assured by our treasurer that there will be some prizes coming at some point, and we will see what it takes to get those to you, but you can expect those coming soon. The third prize winner is somebody who really impressed us with the quality of the presentation, especially. There was a great deal of enthusiasm. It was well structured. The slides were very clear, and it was a real pleasure to watch this presentation. That was really the major strength to highlight. And so the third prize goes to Nancy Wang from Queen's University in Kingston, Ontario. And Nancy, congratulations for your third prize.
Thank you.
Thank you, Nancy. Only to say that the prize itself, the amount of money and that certificate will be sent to you after this. Thank you. So I would invite Ivona Sikangiewski. I really not easy to say the Polish names. The president of ISE, the partner society of ISE, that is leading the ISE 2021, the Congress that would be held in Poland, but it was now virtual because of the COVID-19. The person who have been working a lot to make this meeting possible, to call the second place in this competition.
Dear colleagues, dear participants of this Young Investigator Competition, it's my pleasure to be here as the president of the Congress and as the president of our sister society, International Society for Holter Non-Invasive Electrocardiology, and I would like to congratulate all of you for your hard work, outstanding research, and outstanding presentation, particularly that we gave you very limited time for preparing your presentation. So you really made it. And I have to say that I envy International Society of Electrocardiology, such a dynamic community of young investigators. And I hope that you won't be associated only with ISE, but we can cooperate in ISHNI as well. So the second prize goes to Guilherme de Carvalho from Brazil. Congratulations.
Very pleasure to be here and to receive this award. Thank you very much.
Thank you, Guilherme. I did my cardiology residency in your institution, and I'm very, very happy that you are awarded. Yeah. Give a hug to Dalmo also. Yeah.
I'll send you.
Okay. So now the first prize, that it's not a surprise for a mathematical reason, but please, Bullet, go on.
Yeah.
Bullet is the president-elect that will be the president from the next week on of the International Society of Electrocardiology. Go on.
Thank you, Tom. First of all, I want to thank Rob for his excellent work, and also Ivona for her all efforts to create this Congress, which is really a difficult job. And the biggest award goes to Sharon Lee. She is from the Laboratory of Cardiovascular Physiology, Hong Kong, China. Congratulations, Sharon. Actually, we like your abstract and work very much, and your presentation was also very clear. And every member of the jury thought that it's a really great job, and hope you will keep on working, and hope you will be very active or more active in our society, because we do need such an active person, especially the ladies in our society. Congratulations.
Thank you. It is my pleasure to accept the award.
So maybe you can say a few words as a president of society to Sharon, please.
So we expect to receive you in Belo Horizonte next year in presence. We are not sure that we'll be able to do in-present meeting. Brazil is living a very difficult situation, not only Brazil, but Brazil is now the main hotspot of the disease. But there are many months in the from now to July of the next year. So we really would like to have all of you here. And so with this words, we're very happy with your prizes, and we are finishing this session that will be recorded. It's being recorded and will be available online with the magic of Rob McLeod. So thank you all, and I wish that you enjoy the ISE 2021 and can attend the highest number of conferences you can. Thank you, and see you there.